My name's Will Howard. I'm one of the medical directors at Wessex LMCs, and I am a GP by profession down in South West Hampshire. So very nice to see you all, and thank you so much for joining this Wessex LMCs educational webinar on paediatric paroxysmal episodes. And we're really delighted to be able to welcome Kate Pryde, who is a consultant general paediatrician. You described yourself as, Kate, but also secondary care epilepsy lead at Southampton Hospital in paediatrics. I'll let you add the other bits to your intro, and I think you're going to start sharing your screen fairly soon. So over to you, Kate.
Yeah, thanks ever so much, Will, and hello, welcome to you all. Thank you very much for asking me to come along and talk to you guys about fits, feints and funny turns, as I've called it. Right, I am hopefully screen sharing now, and hopefully you can see my slide.
That's working. That is working perfectly.
Great. I am on a single screen as I'm in a broom cupboard, as Will knows. So I can't see your faces, and I'm sure some people are eating lunch and whatever might have screens turned off. But please, I find it really weird when we're just chatting to a screen. So do interrupt, interject, pop things in the chat, and we'll feed them back. So I was asked to talk to you guys about paroxysmal episodes. And yeah, we could have spent a good couple of days talking about these in children. And I think it's really hard to do a talk that's going to be like a takeaway. Yeah, I know what I'm doing with all of these, because actually, you know, as you all well know, working in the primary care setting, humans don't come like a machine, and there's always something different. And I often say, you know, that's the brilliant art bit of medicine, isn't it? You know, if it was all just science and straightforward, we'd be using AI and computer generated models now. And I think paroxysmal episodes in children particularly are kind of the weird and the wonderful. And so I'm not going to be able to give you lots of hard and fast rules, but I hope I'm going to be able to talk you through an approach to thinking about them. I very much like using a sort of case-based approach to doing so. So I've sort of got, I think, about 6 cases that we'll kind of run through that I hope illustrates some important aspects of things to think about when you're faced with somebody coming in who's had a funny turn. So things that I wanted to cover in the session were kind of to think about epileptic and non-epileptic events in children and what are some of the features of that. Think about important questions to ask in the history, what might be the differential diagnosis, and then really importantly in our kind of joint working together, think about appropriate next steps, where there's red flags that we might want to know about things urgently, when we might want a sort of routine referral, and when actually you might be able to support family and there not be indications for referral up. And also, I think sharing kind of resources and sources of support for families is really helpful. And I've learnt loads from working. I'm the PCN paediatric lead for the West PCN in Southampton City. I don't know if there's any of you guys that work in the West there, but I've learnt so much through running that hub and MDT over the last kind of 6 years. So I think in the spirit of all teach, all learn, please do chip in, particularly on the kind of sources of support for patients and information. I'd be really appreciative. So kicking off, there's a little bit of audience participation as well in this. So first of all, I always start any talk on paroxysmal episodes with it being history. And I'm sure if you see that on your screen or the patient walks in and says that's what it is, it's a bit like, oh, bugger, this is going to take more than my allotted time to do, because actually it does take a bit of time. You need to think about what's happening before, during and after an event. Have they got any awareness? I kind of go a quick top to bottom, you know, what was happening with eyes, face, arms, legs, body, etc. How often are they happening? Are the episodes stereotyped? Are they always the same? Are they at a particular time of day? Is there any association with sleep? Are there particular triggers, as in circumstantial? So they're happening when they're they've always happened when they've been in the car on a sunny day. Are they they're going past trees, you know, thinking of photosensitivity type things? Are they always happening in the home when they're relaxing, maybe thinking something more about a non-epileptic type event? But is there any obvious kind of triggers, associations? Really important to get, if possible, eyewitness accounts, as well as asking the child. And I think sometimes we don't always ask the child. And as cliched as it is, often getting the child, if they can have funny feelings, to draw, we get some really brilliant things that come out in drawings. And then lastly, do say, have they got a video? And if they haven't got a video, top tip, takeaway tip number one is please ask for a video of the event, because enormously helpful, even for us on triage of any of these events. And certainly we're able to turn some of these around and be very reassuring without needing to see them with a video. So tip number one, takeaway number one, get parents to get a video events. So let's kick off with some cases. I've kind of tried to go through sort of from newborn up into the teens. So 3-week-old baby comes in to see you with a 3-day history of rhythmical jerking whilst they're asleep. No other symptoms. They're otherwise well, feeding, gaining weight nicely. So what else do you want to ask? Just jump in.
I'm meant to be asking really intelligent questions, and I'm thinking, oh my God, I've gone completely blank, Kate.
That's all right. So we might want to know something about what was the birth history for this baby, maybe, don't we? Is there anything that's going to be putting them at risk of a sort of perinatal injury? So did they have a normal birth history? Was there anything in their pregnancy that was any problems? Is there any family history of anything going on? How often, as I just talked about with history, how often are they happening? Are there any triggers? When are they happening? So this baby, the events are only happening in sleep, after they've been asleep, usually for 15 to 20 minutes. They're occurring multiple times a day. There's nothing particular other than happening in sleep. And when you sort of go through that top to toe, what's happening, they describe rhythmical jerking of both their hands and sometimes their legs. There's no facial twitching, and they stop if the baby's woken up, and you examine them. That's unremarkable.
Someone's put in the a question or a chat, a sort of a comment. Is in children, especially of this age, is there any questions about dropping the child? Is that something you'd consider looking at and specifically asking?
So you're asking about an injury there, aren't you? So I think not necessarily, don't want to know specifically about, well, dropping the child is clearly important, but has there been an injury? Then absolutely. Is there a traumatic cause? Then yeah, we would absolutely want to think about that. So if we've got that baby that's 3 weeks old, fit and well, having these jerks in their sleep, otherwise feeding, was born on time, no other problems, are you going to reassure and send them on their way with some safety netting, send them home, but try and get to review them again with a video? Are you going to send a routine referral to us, or are you going to give us a call on the advice line and ask for us to see them?
Because I'm a chicken, I'm always going to give you a call.
You're going to give us a call. Okay. And so what I said, you're actually really lucky. This mum says, oh, do you know what? I've got some video. So let's hopefully, is it there?
It is there, yeah.
We've got a little bit of video. I'll try and pop it in full screen. It's got no sound.
Yeah.
This is what you see. Okay.
You've come out of your sharing of the whole screen there. Sorry.
Oh, have I?
Yeah.
Sorry, let me come back to you.
See, I'm the outlier. Everyone else has put 2 on there, number 2 out of your list of answers. Whereas I was the I want to ask somebody what I should do. Having seen the video, does anyone want to change their answer? Does anybody else think? That's it, Kate. You're back now.
I'm back.
Sharing.
So, I think 2 sounds good, because absolutely a video. You definitely want a video of this, because it's always good to check. For me, as somebody that sees lots of this thing, talks to lots of people, because I don't probably see as much, because I can be very reassuring. 3-week-old, otherwise fit and healthy, that is doing this only in sleep. I am, without even seeing a video, 95% sure this is benign sleep myoclonus of infancy. So clues for that are, and I don't want you to go away thinking you're experts, and I absolutely want you to pick up the phone if that's what you as an individual need to do, that's fine, really happy. But just in terms of thinking and gaining confidence, so benign sleep myoclonus of infancy, it's completely benign. It clues in the title. It's an otherwise healthy baby, nothing else of concern in the history. Normal examination. It's the key is that it stops when the child is woken up. It doesn't require any treatment, and it's going to resolve spontaneously, usually in the first 2 to 6 months of life. We all have hypnagogic, hypnopompic jerks to a greater or lesser degree, but that kind of significant amount of myoclonus does tend to resolve in the first 6 months.
Okay, that's really useful, because that's the kind of thing that you're giving the parents a name of something that helps them go away and feel like they've got an answer. And in general practice, quite often, if you're not sure, giving them "I'm not sure" is often not enough, which is when you end up going, "I'm going to pick up the phone and ask somebody." Yeah. Whereas actually being able to say, "Do you know what? I feel reassured. This goes away when the child's woken up. I think this is benign sleep myoclonus of infancy. This is completely benign. Come back if there's any changes to it, or it continues when they're woken."
Yeah, exactly. Then some nice clear safety netting. By the way, I'm super happy, Joe, to share these slides with you for circulating to anybody you're putting on a platform, if that's helpful.
Thank you.
So case number 2, this was a very recent advice and guidance, literally in the last few weeks. I hope I've anonymised. I was really careful to try and anonymise it. From both from the practice and from the patient. So I'll just read it out in case anybody can't for any reason, but attaching my note for this 14-month-old, appreciate advice on which service would be good to review this child. Mum's got a wealth of childcare experiences, seen all the tantrum, breath holding and even epileptic fits before. This sounds different. I'm not unduly concerned. However, I wonder this may represent some epileptiform activity rather than behavioural. I'm concerned not to write this off at this stage. Somebody else review the evidence that I've asked for. So brilliant. I've asked for some evidence. And so then this is the note that I've just literally clipped there. So 3 months of episode. So it's a 14-month-old who's had 3 months of going stiff, straightening out their body, but only or mainly when they're seated in their high chair, their pram, their shopping trolley seat. Also on going to sleep, goes stiff, straightens out their legs, no tongue biting or vomiting, no clonic phase. Afterwards, snaps out instantly with no drowsiness, can be associated with breath holding, but not always. No trigger of frustration, no family history. Mum's worked in childcare, as we've said. Otherwise, normal, developing, and nothing abnormal in the examination. Thoughts? Any thoughts on what might be going on? So for me, when we often get this kind of like mum has childcare experience, or mum works with people with learning difficulties, or mum works with people with epilepsy, etc., or school is used to seeing children with epilepsy. So I suppose one of the key bits from this bit is just don't always, just because they've seen epilepsy or not seen epilepsy, then that doesn't mean that this is, because as we know, epileptic events take multiple types of form. So for me in this, there seems to be some association with something, mainly when seated. They mention when going off to sleep, straightening out their legs. Afterwards, they're snapping out of it instantly with no drowsiness afterwards. So usually if it was a generalized event, tonic-clonic event, there'd be a post-ictal period. Can be associated with breath holding, but not always. And otherwise, a really normal child. Okay, so this isn't this video of this child, but it is another video that I have of a child with the same thing. Have a look. I know that child was laid down. So Any thoughts, having shown you that video?
My view on that, I mean, someone else has said, let's look at the video first, which is exactly what you've shown us. Perfect. And I've seen that and just gone, that makes me really anxious. But it's interesting that the child was trying to grab the book, move the book around, but seemed to have sort of a hyperextension almost of the lower limb.
Yeah, so child's awake, child's alert, aren't they?
Yeah.
Can't tell exactly how responsive are they, but they are alert. There's not a reduction in conscious level. No,
Yeah.
Nothing else in the chat, I take it then, Will?
Just someone's put that the child was aware of what was
Perfect.
going on. Oh,
Perfect.
absolutely.
Okay, so that history is absolutely classical of self-gratification. So a child who is having episodes, often seated, there was a nice clue there, often can also be when they're going off to sleep with that straightening of their legs. It doesn't have to be straightening of the legs, you can get things. Now, this is really, really quite common. It often doesn't sort of involve touching of the genitals at all, which can lead to some of the confusion. More common in girls. Often takes a while to get a diagnosis. As I've said, can happen in car seats, on the floor, high chairs, push chairs. Characteristically, they are either rocking or you get that kind of crossing of the legs and that extension of the legs that you saw there with that little girl in the video. You can get some grunting, some sweating. You can get them zoning out a bit, so maybe being a little bit less responsive. For some children, it's around time of going to sleep, and sometimes children are tired afterwards, which can lead to a bit of confusion with post-ictal, but there wasn't any of that in that history that we heard from that one or in that video that we saw. And some children get cross if they're distracted from it because they're enjoying that sensation. And in some of the sort of younger children, you can sometimes see some kind of fisting or some grasping of objects. So self-gratification, nothing to worry about, but nobody likes talking about it. The vast majority of parents are mortified to very occasionally get a dad who's a bit like, oh yeah. There's actually surprisingly little information about it, though, and distraction is all that's needed. I often say that there's evidence from in utero scans that babies do. There is self-gratification behaviour in utero. It's a kind of comfort thing. Please make sure that there's no shame in this. It's a normal phenomenon. Actually, the main thing is to encourage, if that's happening, it is just to tell, particularly once they start to get to the toddler age, if they're doing that, then that they need to go, and it needs to be something that's done in a private area. There's quite a nice sort of information that was in this. It's almost like a newspaper article, actually, that's just probably the best thing that I've found, that's just kind of normalizes it. So yeah, as I said, I can either try and pop it in the chat once I finish talking, but also you might be able to look it up, or indeed, because I'm going to share the slides, you'll be able to look at it off that. But self-gratification, really common, often in littler ones, usually retain awareness. Often there's that classical history of in a car seat, in a high chair, those kind of things. But again, the video gives it away. Super happy to look at videos.
Thank you, Kate. That's I think we should give a gold star to one of the audience members who got that before you put the slide up and mentioned the diagnosis. So there you go.
Absolutely, gold star to whoever that is. That's perfect. Fantastic. So non-epileptic, so we've sort of covered the infants at the moment, just for the purposes of the talk. As I said, I could talk for several days about it, but clues to non-epileptic infants and non-epileptic episodes in infants. If they're only in sleep, think about benign sleep myoclonus of infancy. Asking about feeding, so thinking about, is it a reflux related? Is it a Sandifer syndrome? Classical kind of getting a head turn and an arm stretch on that. Are they associated with excitement or emotion? So you can get something called benign shuddering attacks. Or is it self-gratification? And then if there's a sort of sudden onset, then think about a cardiac cause. I will come on, clue, hint, hint, to talk about pain and shock and things that happen after that. Clues for epileptic causes. So clearly alterations in the conscious level are going to be associated with movements, would be a concern. If we've got repetitive limb jerking and stiffening, clearly it's all not mutually exclusive. Remember, we've just talked about self-gratification with that kind of limb stiffening. Myoclonic jerking when they're awake. and then sort of other bits to think about. It doesn't, it just will increase their chances of these perhaps being epileptic if there's been a perinatal insult or if there's developmental delay. So moving up the age ranges a little bit. No, I'm not. I've gone back. Sorry. Let's go. Case 3, 8-month-old baby. So they've come to see you with 3 episodes of becoming stiff and turning blue. Started with a period of crying. So thinking back to what we talked about at the beginning in terms of the history, what else do you want to ask? In the interest of time, I'm going to just move on and say,
go for it.
That we want to think about that episode, don't we? So how long do they last and what's happening? So the episodes last a minute and afterwards the child's totally fine. There's no rhythmic movement, but sometimes they're twitchy whilst they're upset. There's not any association with any sleeping or waking. There's no family history of note. They're otherwise totally fit and well. So they often are crying and then they seem to go limp, floppy, and have this twitching. So what are you going to do with those? You've got the same again, reassure, send home, try and get a video for number 2, send us a routine referral, or pick up the phone and ask us to see the same day.
Okay, I'm a number 2 on this one because I think it's probably like a breath holding.
Yeah, okay, great. So I would agree that I was trying to describe a breath holding attack, and I thought that perhaps just popping some info about breath holding attacks and reflex anoxic seizures, which got slightly different physiological mechanisms behind them, but can appear the same. And for both of them, there isn't any treatment required and they can be reassuring. But so the breath holding attacks, absolutely, that was what I was trying to describe with this. They often start with crying. They might have had a temper tantrum, not got their own way, don't want to get in the car seat kind of thing. And they get that crying and then they have some prolonged expiration with their crying, and then they have their breath hold, which leads to hypoxia, colour change, and then they can get some stiffening and twitching of their limbs. But it's usually a quick recovery afterwards. They can be a bit tired and a bit washed out, just like anybody who's had a prolonged period of distress. Whereas a reflex anoxic seizure is a much sudden onset, so they don't usually cry to start with, and that's usually triggered by pain or emotion. It can be something pretty innocuous, like a hair brushing episode, or it can be things like having a blood test or getting a shock or a fright. And there the mechanism is they got that kind of increased vagal tone, which leads to a low cardiac output state, which then means they collapse and then they have the seizure. But again, they have the quick recovery. So if there's any cardiac family history, then I would suggest that we got an ECG, and I suspect for most of you in that age group, then that's going to need them to come up to the hospital. It's not something you probably feel happy doing or interpreting in primary care, but being very reassuring to the family, these don't need treatment. Just letting you know that both of these can be associated with anemia. I'm not advocating at all that you do a full blood count on these children. It's just worth the opportunity to say, oh, how much milk do they drink? Because these often happen in those toddlers who do drink lots of milk and who then don't have adequate iron sources in their diet. So there's a little bit of an opportunity for a kind of making every contact count and just thinking about ensuring that it's only 2 lots of milk a day and that they're on a multivitamin. Okay. So next we've got a 6-month-old boy who's having some regular episodes of stiffening of his arms that have been happening over about 3 or 4 weeks. Doesn't lose consciousness, but becomes upset afterwards. He's otherwise well. So back to what else do we want to know? We want to know, is there any association with anything? So there doesn't seem to be any associations with feed or sleep. They are getting more frequently. They weren't happening, mum noticed something and thought, is it something? But now actually she's seeing this episode multiple times a day. The baby's otherwise developmentally normal. No past medical history of note. And mum has got a video of this. Oh, she doesn't have a video of this, actually, because I couldn't download it off our database, I'm pretty sure. So in this child, what do you want to do? So a 6-month-old who's having episodes, I'm going to do you a little example. Let's do this.
We can't see you, Kate. Can anyone? For some reason, We
Yes,
can't see you. It's like your camera's disappeared.
I'm sharing. Oh, hang on a minute. Let me see if I can you see me now?
No. I don't know what's happened to your video. It was working perfectly earlier.
Oh. That's really annoying, isn't it? Sorry, you can't see me at all. Yeah, it's gone blank, hasn't it? I don't know what's happened. Oh, I'm annoyed. And I've stopped sharing my screen. So basically, what I was trying to let me just get. Sorry, I'm just getting back to where I was in my slides. I was on case 4, wasn't I?
Yeah.
I was trying to. Oh no, and now I've gone having what? I was trying to describe a child here that was having infantile spasms. Okay. That is something that we absolutely want to see on the same day. So these children might present to you any time between the age of kind of 4 months and a year. And the classic history is that they're having extensive movements of their arms. So they're raising their arms, usually above their shoulders a little bit, stretching them out with a flexion of their trunk at the same time. They often, whilst they start kind of infrequently, they then escalate and often are sort of come in clusters, and the child often gets distressed once they're having clusters of them. Actually, I think there's been quite a good sort of public health messaging and awareness about this, because we definitely see these children a lot earlier now, and we'll be asked to see children and people. It's something that families not infrequently self-present to the emergency department because they've then read on the internet that this might be infantile spasms, and they'll come to us having had just 1 or 2. Now, whilst we can get a typical EEG changes on this, actually early on you don't get the EEG changes, so then it's almost tricky. It's almost better when they've come to you, they've waited to see you a few days, because then you're more likely to get the EEG changes, because if the history is good going, then we'll have to repeat the EEG. It is associated with developmental delay. However, that takes a bit of time to come on, and if they're presenting early, then that might not have appeared yet. But those definitely need urgent referral to us. We would do an EEG, admit them, start them on steroids, vigabatrin, involve the tertiary neurology team. But generally, prognosis varies depending if there's an underlying cause and how well they respond.
Can I ask a very quick question? Yeah, just a simple answer. I hope. What's the prognosis for those children? What turns?
Yes, sorry. Next? Well, I said the prognosis varies. It really varies. Some children do very well and respond to vigabatrin and steroids, and seizures remit and nothing happens. Other children go on to sort of develop an epileptic and even sort of developmental encephalopathy, if you like, with continued degradation in their very varied ability. So it's a very varied prognosis.
Thank you.
So toddlers, non-epileptic episodes, I think things that we haven't chatted about in sleep for toddlers, night terrors, febrile convulsions. I had assumed some knowledge about febrile convulsions and haven't covered those, but generally those are generalized tonic-clonic seizures that occur with a fever, although it's often at the onset of the fever. And so parents might have said, oh, the child was completely well, but then they were hot. And they only know they're hot because they're like, oh my goodness, they've had this convulsion. Simple febrile convulsions that are generalized and last less than 5 minutes, we do nothing about. Ones that last longer than 5 minutes, we give rescue medicine. And then ones, if there's a focal element, we will do an EEG to ensure that there's nothing suggestive of any focal cortical dysplasia, etc. We've talked about self-gratification, and we've talked about reflex anoxic and breath-holding episode. So things that might make it more likely in the history for epileptic clues for toddlers. So have we got sudden cessation in sort of play or speech? Are there any automatisms? Rubbing their fingers together, a bit of lip smacking. Is there repetitive limb jerking and stiffening? Is there atonic seizures, so drop attacks, like a puppet having the strings cut, literally dropping to the floor? Often those children injure themselves, knock out teeth, bang noses. Or is there episodes of sort of intermittent limb weakness, then thinking about a Todd's paresis? So, case 5, an 8-year-old boy School have said to parents that they're worried he's having seizures because he's having these occasional episodes where he seems unresponsive and stares, and they've got other children who have absence epilepsy, so they think this is they're worried that that's what this is. So mum brings him along to you, Julie. Mum, when you asked Mum, she said, "Oh, he's always had these periods. We just thought he was daydreaming. He kind of goes into his own world." He's autistic at a mainstream school, however, and there's no family history of seizures. So, any other bits you want to know? Any thinking on what might be going on here?
Anyone got anything else they want to ask?
No? So
developmentally okay?
Yeah, developmentally okay. Developmentally okay, absolutely appropriate. He okay in a general sense,
Yep.
maybe not quite meeting all of his milestones at school, but approaching his age-related expectations at school.
And the duration of the episodes, any other symptoms
really good.
noted? Loss of control.
Yeah, excellent, really important. So these episodes are lasting maybe kind of around 10 seconds, they think, maybe a little bit longer. They're not quite sure. He seems to kind of drift off during them, be unresponsive, staring, not noticing. School haven't noticed anything else. When you ask Mum what does she mean about him going into his own world, she says, oh, when he's at home and he's sat kind of watching the TV, then he might just drift off. And if we try and call him, he doesn't respond. And Mum says that happens, a few times a week. School haven't noticed them every day. Again, a couple of times a week. So that's a not an infrequent referral to us, and we wouldn't put that into our kind of first fit clinic because my suspicion is really low for these being epileptic blank spells or absent seizures, and I suspect those are non-epileptic blank spells, or what we would usually term behavioural arrests. They can happen in anybody, but they are more common in children who have neurodiverse diagnosis, so autism, ADHD, or children who have learning difficulties. It's often when they're kind of relaxing, so that kind of sitting around on the sofa, or it's at school in kind of story time, or when they can't really be bothered, they just zone out. Parents often do that often say, oh yeah, we just thought it was them because they're used to it. One of the keys is that they can be distracted by touch for it. So if they're doing it, if you get them to kind of tap them, then they'll come out of it. As opposed to epileptic blank spells, which would be usually absent seizures, although sometimes when people are seeing a blank spell, it might be because it's a focal seizure, but that's not detail that I think you need to be worried about. But thinking about absent seizures, there's sort of two types of epilepsy where we get absent seizures. So there's the classical childhood absence epilepsy, and that's the primary school age child, so a younger child usually than 8. So absolutely, when we get this kind of 13, 14-year-olds that are referred like that, not the 8-year-old, we'll often write back and say we don't need to see them. But the children with classical childhood absence epilepsy are usually primary school age. They are having kind of 20, 30, 40, 50, 100 a day of these episodes, lasting 5 to 10 seconds. They're blank, they're unresponsive. Their eyelids may or may not flicker. They might get a little bit of lip twitching. They might get a little bit of finger fiddling. So some of those automatisms. Juvenile absence epilepsy, those children are a little bit older, sort of the key stage 2 age usually, and those episodes last a bit longer, so they kind of last 20 to 30 seconds and have a few less a day, sort of 5 to 10, so basically the number bit reversed. And in those children, the worry is that they can have generalized tonic-clonic seizures. So blank spells, definitely think about neurodiversity, think about the situation that they're happening in. If they're happening in all situations, you know, when they're in the middle of walking across the road, they stop in a football match, those kind of things, much more likely to be an epileptic blank spell rather than a kind of behavioural arrest. And then one of the keys is, can they be distracted by touch? Not calling their name, not waving hands in front of eyes, but can they be distracted by touch? So, case 6, an 11-year-old girl who collapsed and had a fit at school. The teacher report that she suddenly collapsed to the floor. She became unconscious, went stiff, and had some jerking of her limbs for 30 seconds. She vomited, and she was quite tired afterwards. She was able to walk to the medical room, and she was lay on the couch. Otherwise, well. Thoughts here?
Any thoughts from anybody? My initial response to that fairly outline is that she's fainted.
Yep. Why do you think she's fainted, Will?
That's a really good question. Probably because she actually didn't have any other. You haven't described any other features of other things going on with that would make me fearful that she tongue biting, loss of bladder control, those types of things.
Yeah, so
right age group too.
Yeah,
female.
So definitely the right age group, and she's female, isn't she? Loss of bladder control and tongue biting aren't particularly discriminatory, and when you look at the studies for evidence, not a lot of evidence to say definitely discriminatory. I think drooling, but and more discriminatory in the non-epileptic. Do you see what, you know, as in when we get into the realms of is something non-epileptic or not, because children do tongue bite in non-epileptic episodes. Drooling is more accurate and a more reliable indicator. If I'd have written that she went pale and her hearing was muffled, and they were doing their heart dissection, then you're kind of definitely going to go, she's fainted and had a convulsive syncopal episode, aren't you? I think this, you know, where it's really key to ask the child what happened, because they'll usually with a faint will be able to say, oh, I felt dizzy and sick, or those kind of things, but the classic being dizzy, sick, hearing goes muffled. They usually, so let me just show you. Hopefully this works, because I know when I came out of it last time, it didn't work.
Yeah, that's working.
I know it's blurry, but this is German medical students, for anybody who hasn't seen these videos, hence they're from about, I think they're in the 70s. They basically got them to hyperventilate, do a Valsalva, and then stand up. And then, as you can see, they have this kind of asymmetrical tonic-clonic movements. Brief, last only kind of 10 seconds or so. We don't need to see any more of that. Am I still screen sharing?
Yes, you are. Perfect.
Okay. So clues for convulsive syncope are that, you know, classically you get that kind of prodrome, you classically would get a colour change, you get a relatively rapid recovery compared to a generalised tonic-clonic seizure, in that they're able to get up and walk to the matron's office, they're able to walk to an ambulance if an ambulance has been called, but they do often feel tired and washed out. So you've got to take that history carefully, back to what I said on that very first slide. It's all about the history. So it occurs in about 10% of faints. It's probably more common than we think, and it might recur, but it isn't linked with epilepsy. So if you've got a child coming to you who's had convulsive syncope, or indeed if they're a recurrent fainter, then I think an ECG absolutely is warranted and should absolutely be done if there's any cardiac family history. If they're recurrent episodes, I think there is a case for doing a full blood count. Again, there is an association with iron deficiency, so doing a full blood count and a ferritin sensible. Really important to give some lifestyle advice around hydration and nutrition. And I think that there's an awful lot of young people these days who don't drink adequately, particularly in the early part of the day, will kind of hydrate in the later part of the day, and that can become a problem, particularly for girls around menstruation. And then the other bit of I put it in the lifestyle advice, but actually just, telling them to get up slowly, that actually if they've got any of those warning feelings that they need to sit down, put their legs up, etc. I don't need you to tell them. The red flag for syncope is during exercise. Absolutely. If there's syncope during exercise, then they need to be referred urgently, and we'd see them in a rapid access clinic. So that was convulsive syncope.
Ace, it's a really interesting one. That I saw a whole group of kids one evening that were all brought into the practice because they'd had a whole load of episodes in their school, and they'd all been doing dares to do the hyperventilation followed by Valsalva, and they all collapsed. And then someone walked in who was a member of staff and said, "You all need to go to the doctor now." And it was just like, I saw my urgent care list saying convulsion, 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 convulsion. Oh my God, they'd all been doing that.
Oh dear. Yeah, absolutely. And it is quite a worry, isn't it, with some of the kind of TikTok, other social media platform kind of crazes that exist for these kind of things. So yeah, but again, I think it's one of those things that labeling it and saying, rather than saying necessarily it's a faint, saying it's called convulsive syncope. Actually, this happens in 1 in 10 people who have a faint. It's okay. That's all right. Moving on, tics, I think those come under probably into this result, certainly of paroxysmal disorders. Now, tics are they've become a big phenomenon sort of during COVID. They've died down definitely a bit. And actually, in general paediatrics, we don't see tics, and we'll push them back to people. But I think it's really important to just think about tics in this, because, and the reason we don't see them in general paediatrics is that if you've got the diagnosis, we don't need to see them, because we're not the ones that would start any treatment, and actually the thresholds for treating are incredibly high, and it's CAMS that would initiate either CBT or potentially medicines. But they're super common in children sort of from the age of 5. They peak in that kind of adolescence, moving to secondary school age. I'm sure you're seeing them really regularly. I'm not telling you anything you don't know, in terms of the fact that, they wax and wane over time, and different parts of the body can be affected. They can be motor and or vocal tics, and can be very simple tics. I'm sat here trying to show you, but of course my video not working isn't helpful. Or they can be quite complex tics, involving kind of multiple body parts. And you've got classically got that premonitory urge, and you've really got to kind of they need to let the tic out, otherwise they're suppressing it, then they might have that a bout of the tic. So I think that the main thing here is, if you're happy that the tic is the diagnosis, then management is absolutely, it's conservative, and it's about reassurance. It's about telling them to ignore the tics as much as possible, and reducing any potential sort of stresses or triggers for it. And most of them will resolve without medical intervention. The majority have improved by adulthood. For a very small minority, adulthood does become the worst time for their tics, but I don't ever tend to say that. I say the overwhelming majority will resolve without intervention by adulthood. So there's a couple of, unhelpfully, the Tourette's Action website has got the best information leaflet on it, and it's got sort of suggestions of other things they can do depending on what their tic is. But it is obviously the Tourette's Action, and Tourette's needs to be a combination of complex motor and vocal tics. So I always stress to families, it doesn't mean that your child has got Tourette's, it's just that that's where there's some useful information. But also on the Wessex Healthier Together page, there's quite a lot of different resources on that Wessex Healthier Together page. CBT, and then there are a number of drugs that can be used, is the realm of the psychiatrists. Obviously, crazy weights for those, and there needs to be a significant impact on quality of life in terms of, you know, not attending school, etc., to be in order to be able to kind of meet the threshold be seen by them. We would happily see if there's concerns about obviously if there's a neurological abnormality on examination coinciding, or if there's any developmental regression, or if there's, you know, more generalised diagnostic uncertainty. I think it's being really clear that we're not the route for treatment of tics. It just doesn't fall within our remit, which, you know, it can be challenging if parents think they've come to see us because of that. So it's just being clear that that's the role of the general paediatrician and where we can help. Non-epileptic episodes in children. So think about prodromes, you know, that classic description there of a faint, dizzy, sick, as I said, muffled sounds. If you've got faints, then do an ECG. And I talked about the association with low iron. If we've got episodes only in sleep, then think about parasomnias, night terrors, associated with fever and intercurrent illness, obviously febrile convulsions, but also syncopal episodes with intercurrent illness. Specifically with movement, then are we talking about kind of movement disorders, dystonias, dyskinesias? Associated with pain, are we thinking about reflex anoxic seizures or syncope, or potentially a cardiac cause? And then if we've got sort of stress and anxiety, are they non-epileptic attack disorder dissociative events, or is there a tic? And if they're kind of associated with boredom, is it daydreaming? Things for epileptic clues, and I didn't want this to be a talk about the different types of epilepsy because I don't believe that's the remit of primary care, pediatrics in primary care, to think about what is the epilepsy diagnosis. But if you've got a child who's having events in the early morning, then I'll be thinking about, have they got what used to be called benign Rolandic epilepsy, these days called self-limiting epilepsy with centrotemporal spikes, or SELECT. And the sort of classical history for that is that parents are woken by a child making an odd noise in the early hours, kind of 4 or 5 in the morning, and they go in and the child's trying to speak but unable to speak, and they might have some abnormal posturing of their arms, and then they go into a generalised tonic-clonic seizure. That's the kind of classical history for that. Clearly, if we've got that history of an event that we think is a generalised tonic-clonic seizure or a focal epileptic seizure, we want to see them regardless. If we've got drop attacks that are significant, causing injury, we absolutely want to see those. If we've got myoclonic jerks when we're awake, and if we've got any kind of funny turns and funny events with speech regression, then we might be thinking Landau-Klafner. We're getting into the rare stuff now, but yeah, that's where we might be. So the Wessex Healthier Together pathway, I think, you know, people are generally really au fait now with Wessex Healthier Together as a platform for looking at, but hopefully I've gone through those kind of bits in the history, you know, thinking about before, during and afterwards. Are they able to be distracted? Is it occurring during exercise? What's happening in their past history and their developmental history? Any family history? Are there red flags? And we've listed the red flags for kind of acute assessment there. So if they're less than 1, if they're confused, if there's pervasive behavioural change, if there's recurrent convulsive seizures of more than once a week, abnormal cardiac or neurological examination, and obviously if there's signs of raised intracranial pressure or of sepsis and acute infection, then a kind of urgent one. If you're thinking that this is a possible epileptic seizure, or you've got diagnostic uncertainty around some of those non-epileptic things that I've talked about, and we really appreciate that everybody's experience is different, then you can do a non-urgent referral, and I'd encourage you to do advice and guidance for the kind of the diagnostic uncertainty bits. And if you work in a PCN in the city or in Lymington, New Milton, where we've got the hub MDTs, then that's an ideal place to discuss one of these cases. But if you're happy making a diagnosis that it is a vasovagal event or a convulsive syncope or a sleep, myoclonus, etc., any of those other things that we've talked about or listed there, then that's fine. We absolutely don't need to see them. And I think that was me done.
Amazing.
Any questions?
Okay. Any questions from anybody? Please feel free to either pop them in the chat, stick your hand up. It's absolutely fine. Okay, it's so useful. For me, the history is just it's kind of part and parcel of good medicine, isn't it? It's what you're taught at medical school. Is actually your history is the key to diagnosis. In essentially, an examination just adds a little bit more information, and it's a bit like taking a history from a patient with frailty who's fallen, and it's actually about the process of the fall. This is exactly the same type of process in a child or from the parent or guardian of a child, and for me, that's kind of the take-home message. The other bit is, what's really, really interesting is that you've just described loads and loads of episodes which are benign, but which parents might present to their GP that we're going to go away and try and reassure them about, which can be quite difficult in primary care, because obviously parents will have different levels of sort of fear or anxiety, and anyone who is a parent completely understands that. It's terrifying when it's your own child. So I'm always interested by the amount of risk that we in primary care are willing to take and do generally manage quite effectively.
I totally agree. I'm really sorry that my video, I don't know what's happened to it. It's come up saying something's gone wrong. Please rejoin the meeting. But I think in the interest of time, it's probably best to just hear my voice. I'm super sorry about that. I'm not sure what's happened. I absolutely think that it is. And I hear what you said earlier on about it really helpful when you're able to make a sort of positive diagnosis. Oh, this is benign sleep myoclonus. Oh, this is a breath holding episode. That's really useful for them. And one of the most difficult things that I talk with families about is actually often I am holding uncertainty and I don't know what the diagnosis is because it doesn't fit into a category neatly. And then I've been asked to see it. And actually there's still diagnostic uncertainty, but time is going to be my most helpful investigation. And in the world we currently live in, very few people are comfortable with time, but actually it is the most helpful thing, particularly because an EEG isn't a good investigation. It's not sensitive, it's not specific. I think I'm always impressed by the amount of risk that primary care holds. Equally, the fact that actually, because I have a clinic every week that sees children with epilepsy, but by that I've filtered out things. So super happy to sort of to get advice and guidance, queries, give advice on this. We are as a wider team, but us in the epilepsy team particularly.
Amazing, thank you. Anyone who works in a place that has got one of the paediatric hubs, this would be a great example of something to sort of take to a hub or book into a hub. That's really, really useful when you have that MDT approach in a community setting. That's really, I found it very, very useful when I've worked in those places. There is a question, if I may ask you it, in the sidebar. In a syncopal event, when the patient is up and walking again, can residual myoclonus jerks continue? And what's the normal time range until they may resolve?
So I'd say, yes, they might have an occasional one. I can't give you a normal time frame until they resolve in terms of, if they're still going on after an hour, that's abnormal. What I would say is if there's myoclonic jerks happening outside of a syncopal episode, then yes. I think we would absolutely want to see, because we're thinking about juvenile myoclonic epilepsy, in which often the first time they present to us is with a generalized tonic-clonic seizure, but then on further questioning you find out about the myoclonic jerks. And so I think if there was a history of a reasonable amount of myoclonus in somebody who was having a syncopal event that you thought was a syncopal event, I think that would be one where I'd be thinking, is it definitely syncopal, and is it definitely not a generalized tonic-clonic seizure? Do you see what I mean? So I think syncope and myoclonus would just raise my suspicion that we're not talking syncope. It doesn't mean that we aren't, as it were, but I'd be happy to. That would be one that we would probably see, because actually by us seeing, we've again got that time.
It kind of counterbalances the risk. It takes the risk the other way a bit, doesn't it? So I'm not reassured this was quite so much a syncopal event, because there are some things that make me question that diagnosis.
Yeah, absolutely.
Yeah, that makes sense. Okie doke. Anything else before we sign off? There's nothing else in the chat, and I've got an entire side of A4 which I've scribbled down while you were talking for my portfolio, which is really, really great. So thank you so much, Kate.
I hope it was useful.